I would say, I guess you need the colleagues with the right mindset, which was actually not the highest barrier. You need to practice 7-day working in a way that the Saturday, Sunday is exactly the same as the weekday. And the challenge there is you're spreading your resources. So if you are taking resources out of the week, if you work a shift system, and you can only work so many hours, then you simply need to replace that in the week. So all sort of consultant bodies and all staff that you're taking on board with that, they need to expand. And then I guess the second challenge from my point of view is the interfaces that you work with. When I am there, I can only do so much as the supporting departments around me. We're very fortunate here that the pharmacy, radiology do a lot more than I would have seen in other trusts. But even though it's more, it's still not as much resource as you would need to operate it on a normal workday. So it's come a long way. It's brilliant. I would say this is probably one of the best I've seen, and I've worked in many hospitals. But again, to make it equal to a working weekday, all these services need a complete uplift in resources. And again, spreading themselves thinner, moving resource from the weekday into the weekend. Yeah, I think that's the main thing. And other interfaces, of course, the usual, the community, and getting patients discharged. You don't have social workers and the social interfaces that you can communicate with like you have in the week.
I think for the workforce, rightly, as Sven mentioned there, this is a big challenge. You've got the same number of clinicians and you need to spread it out over 7 days. So that's one of our biggest challenges, especially from specialty point of view. Acute medicine is really difficult to recruit people. So people with the right mindset, the numbers is important. We've been lucky. We've got about 9 consultants at the moment in acute medicine. We work independently, actually. It's a closed kind of department. We don't have other specialties coming in. So that's part of the thing, how we implemented 7 days working across all of medicine. So every other department actually also works 7 days. They are not coming into acute medicine, but they actually work 7 days in their areas. And really what we've done is we've kind of divided the take is purely managed by acute physicians, and the rest of the hospital, in terms of the rest of medical division, actually, you got clinicians also doing 7 days, so they'll come in on weekends and do that. Challenge obviously is having everything else, the supportive from radiology, from pharmacy and all of that, and that's been really good as well. So unless and until that happened, purely a clinician doing 7 days wouldn't have worked. So that's been one of a challenge, but at the same time we've managed to achieve that as well. This is how the job plans we've done is about changing it into a shift pattern, especially in acute medicine. So there are people who are working weekends, they will get part of or evening shift, or part of the job plan frees them off during the daytime. So, and that's a different model in medicine. It's a bit like when you go into emergency department. It's a similar kind of job plan. So, as Sven mentioned initially, it's about making it a 7-day job plan rather than having a 5-day with an add-on of the weekends and evenings. So that's how we kind of achieved that.
I think you create gaps in the week, and the mitigation for that was employing locum consultants. That's been difficult because I think we've probably set the bar higher in Stoke than everywhere else by having 7-day services for all specialties like ZSS. So if you only have the ambition to have a consultant there for 12 days, all services, the AMU as well as the specialties, then you can tap into the pool of 20, 30 physicians. That shouldn't be so difficult. But actually we have to put basically at least 3 consultants onto the shop floor on AMU on weekends. And since the specialties are doing their own ward rounds, which is great, you have respiratory, diabetes, elderly care, doing ward rounds producing flow, but it means we have to make up for the deficit. All the consultants have to come from acute medicine. So we're employing local consultants. Recruitment in acute medicine as a young specialty is tough, we know that. So one compromise is financial. The few good consultants out there will often work for agencies, and there will be above cut rate. So financially, the trust took a hit. But I believe we can demonstrate that our unit doesn't suffer performance on the weekend at all. We do exactly the same thing, the same stuffing. Nothing is different on the weekend.
Oh, well, from patient point of view, we're achieving the recommended national within 14 hours to be seen by a consultant, so that's been great. In terms of our flow, I mean, one of the things is managing patients within the 48 hours from an acute medicine point of view, so we've been able to achieve that. Managing discharges within the same day, ambulatory care, we've implemented that, so that's obviously from patient perspective, getting them home the same day, preventing hospital admissions, and obviously hospital acquired infections, and all that benefit because of this, certainly. I mean, the same with the rest of the division, managing that consultant presence on the floor 7 days, that's been good in terms of patients, sick patients being seen by consultants every day, patients for potential discharge being seen the same day. So that, again, in terms of flow, we've seen an impact on that. Patient care in terms of morbidity and mortality has been better as well.
I think this makes a difference to the medical registrar. I think the role of the medical registrar has had a bit of a beating nationwide. And I think one reason is that the registrar used to be like a sort of troubleshooter for absolutely everything. The hospital grinds to a halt on the weekend, the ward rounds don't happen, and the registrar picks everything up. And I believe that has made a huge difference. If there are ward rounds going on all the core wards, then there is very little for the registrar to pick up, and they can concentrate on what they're meant to do, is see the sick patients where there's an urgent intervention required, and work with a take team, again, under direct consultant supervision and led. I think psychologically, we have a lot of patients who are anxious about what they read in the press, that on weekends hospitals are more dangerous. And we can reassure them that in our hospital, the service we provide on a weekend is exactly the same in terms of staffing, consultant present as during the week. And that feels very good to be able to credibly say that and reassure people.
So we're achieving about 95% for that. We got consultant presence from 8 in the morning till 10 at night. So, and 8 in the morning again. So you do manage to see the patients within 14 hours. I guess one of our challenges is being patients who are boarding within ED, and trying to achieve that 14 hours has been a big challenge for us. Now we started to reach into ED, and that's a bit better at the moment, but still it's been a big challenge. As mentioned, we've got 3 consultants now on the floor at a time, and one of them who will be doing the take will also reach into ED, so we are managing to maintain.
I say to my colleagues, I can't change the fact that we do acute work, and that has to be done out of hours. We have to have the ethos to deliver that, but you have to be compensated by it to actually job plan properly. That is not on call, but it's properly planned and remunerated job plan hours. So it will fill up the job plan very quickly, and you will end up with time off in the week. So 14 hours, no, that's not one shift. We have 8 till 5:30, and then we have 2 colleagues doing an evening shift. On the weekend, however, we're doing 12-hour shifts. That is sort of the longest college-endorsed shift. The way we do that is, the philosophy is 7-day working can't mean that one poor person works for 7 days every day. It means the cover is provided for 7 days, but this has to be sustainable. How? If I work the weekend, I do 12-hour shifts. That's quite tough, but I will never do AMU on a Friday before or on a Monday afterwards. So you have to actually give people rest time and compensate for the intensity before and after. And I think that's where we need to learn even more from specialties who've been doing that for a while, A&E, pediatrics, ITU. So we have to have a proper shift system where the intensity then gets followed by time off.
Which has been a challenge to sell to the Royal College, actually. They don't, well, I mean, they don't probably endorse that kind of model for acute medicine at the moment, but I guess in the future, we're sure that will be adopted, and especially if we want a 7-day.
It's difficult to see how different it would be, because medicine is not the only profession with 7-day workings. The supermarkets, train drivers, pilots, all of them have in common that they provide the same service in an unsociable time, and they get compensated for it at other times. And how can that be different? Unless we go back to the time when doctors are allowed to work double the time of everybody else. But surely that's not safe, not in a profession where you have people's lives in your hands. So it's difficult to come away from a shift system, because I think if you call it on call and the activity is not the same as it gets delivered during what we would call traditionally core 9 to 5 days, and then you're also not providing the same service. So it's difficult to see how, other than a shift system, it can be delivered.